Yes, starting with the immune system and systemic diseases, systemic lupus erythematosus. SLE is basically a systemic autoimmune disease with damage to organs and cells, which are mediated by autoantibodies and immune complexes which are directed against the body's own RNA and DNA. Mostly it affects the childbearing age females, like male female to male ratio is 9:1. This is the classic presentation of SLE, butterfly rash. The young female of childbearing age presents with this classic presentation of butterfly rash that involves the skin. So, etiology of lupus is the antibodies are directed against the patient's own DNA and histones, also non-histone RNA and nucleolus. So this is now, if the antibodies are directed against body's own RNA and DNA, then it will affect these antigen antibody complexes are going to damage almost all the body organs, and they get deposited in skin, joints and kidneys and vessels as well. The proposed model for pathogenesis is the progressive deposition and inflammation of immune complexes in skin, joints, renal, kidneys, vessels and heart and CNS also. Morphology is like the patient presents grossly as butterfly rash, and if it only involves the skin, dermal epidermal junction of the skin, it presents with discoid lupus erythematosus and glomerulonephritis. Most common presentation is the renal presentation, like young females, if it's presenting with renal failure, the most likely diagnosis is SLE. And clinically, a patient present as progressive renal and vascular disease, and in serum there is positive anti-nuclear antigens, ANA positives, ANA positive. Pathogenesis of SLE, like we have discussed, certain genetic, there is genetic predisposition like human leukocyte antigen D2, D3 and D8, and certain deficiency of complement factors like C1q, C2 and C4, and that is triggered by certain environmental factors like ultraviolet light, female gender, infections, certain infections that trigger the process of apoptosis, and this apoptosis releases nuclear DNA, and this triggers the abnormal immune response like B cell, defective B cell response and T cell response, which results in formation of autoantibodies. These antigen antibody complexes then further complemented by the activation of the complement system C3, and these get deposited in the skin at the dermal epidermal junction and leads to classic clinical presentation of butterfly rash and get deposited in kidneys and glomerular basement membrane and causes nephritis and the blood vessels, and that results in atherosclerosis, and this further deposition causes the release of cytokines and a chronic inflammatory process that causes the organ damage. This is another flowchart like shows like immune complexes. In genetic predisposition, certain environmental triggers as ultraviolet rays trigger the innate immune system activation, and this innate immune system activate the adaptive immune system activation. So innate system is get activated through, and damage take place through TLR toll-like receptors, and then this further activated by the activation of B cell through peripheral tolerance and failure of peripheral tolerance and T cell activation, and results in formation of antigen antibody complexes. And these antigen-antibody complexes then trigger the clinical disease, and there is a remitting and relapsing course. Like it get settled, the disease course gets settled and reactivated after a certain period of time, and that results in irreversible tissue loss and can lead to atherosclerosis as well as. Similarly, these antibodies can cross the blood-brain barrier and can cause parenchymal brain toxicity. Autoantibodies in SLE. Now, most common antibodies that are detected are anti-nuclear antibodies, like 98%, and is the best screening test, and anti-double standard DNA antibodies are present in 70% of the cases and specific for SLE, and it correlates with disease severity. Anti-Smith antibodies also specific for SLE, and certain autoantibodies are like anti-RNP, anti-Rho SSA, anti-La SSB that can be detected in certain conditions in SLE. Anti-nuclear antibodies are present in 4 to 5% of healthy population, but up to 14% of elderly or chronically ill patients. The sensitivity is very high in SLE, but specificity is low. And it is also associated with certain other diseases like systemic sclerosis, inflammatory myopathies, Sjogren's syndromes, and polymyositis. There are certain patterns that are detected according to the deposition of these antibodies, like peripheral or rim pattern, homogeneous pattern, speckled pattern, centromere pattern, and nucleolar pattern. Now, this is the homogeneous pattern in which the you can see the homogeneous distribution of these antibodies. So, and this is the rim pattern in which it gets deposited in a rim-like pattern, speckled pattern in which they are distributed in a speckled pattern, and nucleolar pattern like in the against antibodies against nucleolus and get deposited in a nucleolar pattern, and that can be detected by immunofluorescence. Most common other like is SLE also present with vegetations. These friable vegetations are present on both sides of leaflets. And these Liebman Sachs vegetations are characteristic of SLE, as they are present on both sides of the leaflets of leaves, and this is the only condition, like you can say, that presents with vegetations on both sides, and the patient presents with. And then the renal diseases and central nervous system and pericarditis or inflammation of the pericardium, gastrointestinal symptoms or pruritus, myalgias, fever, fatigue, and weight loss. These are the other symptoms by which patient can present in SLE. Now, treatment. Treatment is basically to prevent the flares and treat flares when they occur and minimize organ damage and inflammation. Basically, patient presents most commonly like as we had discussed through renal manifestations, nephritis, and the main cause of death in patients with SLE is the renal failure and other infections, and so that is the life-threatening SLE if it involves CNS and renal. And most systemic autoimmune diseases are like rheumatoid arthritis, Sjogren's syndrome, scleroderma, and also called systemic sclerosis, and periarthritis. Rheumatoid arthritis we're gonna discuss in detail in chapter of bones and joints, but basically it's a systemic disease in which antibodies are directed against the Fc portion of IgG against its own antibody, and this results in damage to the synovium, joints, blood vessels and other organs, as well as shows the normal synovium, and it's double layered, like one monolayered and one other of histiocytic or macrophages like cells that lines this double layer synovium. Now what happens if in rheumatoid arthritis, this is filled with this inflammatory cells, RBCs, neutrophils, and lymphocytes, and this causes destruction of this synovium, and this results in this patient presents with joint diseases and rheumatoid arthritis that results in destruction process, like further deformities can also take place.